So if you've been in this field for more than a couple of years, you can probably remember the days when everybody and their dog, it didn't matter, every man, woman, child, dog, cat, infant, goldfish, anyone who was within 50 yards of a fender bender, if you were in a vehicle accident, no matter how minor, you got strapped down to a backboard. In the early 2000s, we immobilized at least 5 million people every year, most of whom had absolutely no complaints of neck or back pain and had zero signs of neurological deficit. But it didn't matter. If you were in the car, you got a backboard, period. And that was the way things were for decades. In fact, pre-hospital immobilization first came about in the 1960s. A lot has changed in recent years, and now we have things like spinal clearance protocols. And taking it one step further, every year more and more agencies are removing the backboard entirely from their protocols. Backboards around the globe are beginning to pile up in a garage somewhere, collecting dust. Now, my question to you is, when these changes first came about, were you at all skeptical? In fairness, I'm a skeptical person by nature, and my philosophy tends to be trust but verify. So I set out to look at the so-called evidence and see where the mistakes had been made. And so I spent quite a bit of time reading literally hundreds of research articles spanning as far back as 1989 and up to the present day. And I found out that the reality of the problems with traditional immobilization were far more extensive and severe than what I could have imagined in the first place. Worse, actually, than what I had been led to believe. So the question, though, is, does traditional spinal immobilization to the long backboard cause more harm than good? And if so, what are we supposed to do with these patients? And more specifically, are there any proven, scientifically proven alternatives that have been demonstrated to have better outcomes? Because what difference does it make if we quit using one thing that doesn't work, only to switch to something else that is equally as ineffective or harmful? So lastly, more recent research today, is it supporting the changes that we've made, or do we owe the backboard an apology? I want to start out here by telling you a quick story. Many of you have heard this before, but our story begins on a Friday the 13th, which should be a clue to the kind of story this is going to be. Now, I'm not a superstitious man, but had I known what was in store for me that particular night, I think I would have called in sick. Now, at the time, I was about 2 years into my marriage with my wife, who at this time was about 4 months pregnant with our first child, and life was going very well. I had just received my paramedic license in the mail that very morning, and things were going according to plan, better than I could have hoped. But as Murphy's Law states, if something can go wrong, eventually it will. So I'm working as an EMT this particular night, and it's about 11 o'clock, very dark. My partner's driving the ambulance. I'm half asleep in the passenger seat, and we just finished a long-distance transport. We're on our way back to our station, going down the highway at about 65 miles an hour. It's a very rural area, nothing but trees and farmland as far as the eye could see. Well, all of a sudden, my partner breaks the silence and shouts, "Is that a horse?" And I look up, and the last thing I remember seeing is the face of a 2,000-pound draft horse coming through the windshield right on top of me. And then everything went dark. The next thing I recall is waking up about 30 minutes after the collision, confused and shrouded in darkness. My face is covered in blood and broken glass, blood streaming into my eyes and my mouth from a laceration on my forehead. And as I slowly begin to regain consciousness, I become aware that my partner is holding my head in line. He tells me that we've been in an accident. And then he tells me how it happened, that we had hit a horse. And having a concussion especially, I honestly believed I was dreaming. I repeatedly made the statement, this cannot be real, this is not happening, this is all a dream. None of it made any sense. And at the time, I had no idea where I was. I couldn't even tell that I was sitting inside an ambulance. The cab was unrecognizable and every light was out. But despite my confusion, one thing did not escape my attention for even a moment, and that was the pain. This excruciating, fiery pain across the entire left side of my body. I look down and find that my left wrist is badly angulated and swollen. My side of the ambulance had been ripped apart as though it were made of tinfoil. Interestingly, my partner was treated and released at the scene with minor cuts and bruises. I took the full force. I was flown to a hospital in Quincy, Illinois, where it was determined that I had suffered a concussion, as well as several broken bones, including 4 bones in my wrist, as well as fracture of my left scapula. And I was also told that my neck was broken at C5. Now, I remember thinking, that's impossible. My neck doesn't even hurt. But I'm going to put a question up here just to see what you guys think. Why is it, oh, I'm sorry, I didn't have a question for this, but just in the back of your mind, answer this question for me. Why do you suppose I didn't feel any pain in my neck? You probably answered this question immediately without hesitation. I had a distracting injury. The pain in my wrist was so severe that even if I had been experiencing pain in my neck, it was essentially overridden by the other pain in my body. Well, another blackout, and I wake up at Barnes South. There's a nurse practitioner in the room holding a CT film in her hand. When she lifts it up to the light, this is what I saw. I had a teardrop fracture of my 5th cervical vertebrae with posterior displacement of C5 and C6. My spinal cord was compressed on one side, bulged on the other. Literally, I had come millimeters away from death, or at the very minimum, paralysis. What they believe happened is, as the horse came through the windshield, I raised my left hand to shield myself. The horse impacted my wrist. Wrist came down on top of my head, causing the fracture to the bones of my wrist and compression and the fracture of my 5th cervical vertebrae. And the force continued to travel down through my body, ultimately causing the fracture in my left scapula. Quite a bit of force to cause that kind of injury. So in the hospital, I was told that between the damage to my neck and my hand, I would in all likelihood never be able to work again, not even as a telemarketer, let alone as a paramedic. I was told to forget about that. In fact, the surgeon told me that because my cervical injury was so unstable, there was a very real chance that I would come away from the surgery paralyzed. And so what is it about a teardrop fracture that makes it so unstable? Well, with other types of spinal fractures, this structure called the posterior longitudinal ligament remains intact and basically continues holding your spine in alignment, preventing vertebrae from shifting into the spinal canal. Well, in my case, this ligament was disrupted. Teardrop fractures are very rare, making up only about 15% of all C-spine fractures. And 91% of people who have this kind of fracture will suffer severe neurological damage, including anterior cord syndrome, which we'll discuss in more detail later, which manifests as quadriplegia and a loss of pain and temperature sensation below the level of the injury. Something else that I had been at risk for because of where my injury site was damage to the phrenic nerve. You probably remember the saying from as far back as EMT school that C3, 4, and 5 keep the diaphragm alive. And the phrenic nerve comes out of the spine somewhere in that region of C3, 4, and 5. So there was a possibility that my phrenic nerve could have been damaged too, which would have cut off innervation to the diaphragm, your major muscle for breathing, which would have left me with not much more than my intercostal muscles, accessory muscles to breathe. And because it took almost 30 minutes for another ambulance to arrive at my accident scene, I, in all likelihood, would have been dead before they could have arrived. So thank God I dodged that bullet. This is the one and only picture of me in the hospital, and that is because I specifically told everyone that I did not want any photographs taken. I mean, this was a devastating event. In what world would I ever want to have some memento of this day in my life? Now, don't let the grin on my face, the brave face there, fool you. I was doped up on so much Dilaudid that I had no idea there was a camera in the room at this point in time. And my father-in-law evidently did not get the memo about no pictures to be taken. Thus, the reason why we have this today. Long story short, I went through an anterior-posterior fusion of C4, 5, and 6. This is me today. There is nothing left of C5. Instead, I have quite a bit of hardware, brackets, and screws, along with, if you see this rectangular structure here, that is a bone. It's just not mine. It is a donor bone. I'm told it's actually a portion of a leg bone, a tibia, I believe it was, from a cadaver. So someone's leg bone is in my neck. Now, by the grace of God, I came through everything unscathed, obviously. Six months from the day of the accident, and I was back on the truck. So definitely a miracle in my estimation. So maybe that gives a little bit of context to why I was so skeptical and a little bit nervous about seeing these changes in spinal immobilization when they came out a few years back. It made me nervous because of my own experience and realizing how close to paralysis I had come. So a change of this magnitude, doing away with the backboard essentially, I was uncomfortable with a change like this without having a firm grasp on the evidence that supported this change. So traditional immobilization, it came into being not because of scientific evidence. It was just simply seemed to make sense. You break your arm, you splint it. You break your leg, you splint it. So obviously you break your neck or your back. What's the solution? You splint it. And the backboard was just seen as a full body splint. But as EMS shifted focus towards evidence-based medicine, a number of studies began to come out questioning the efficacy of traditional immobilization. You see, it all came down to a question of cost versus benefit. So this is what the researchers examined. First of all, what are the scientifically proven benefits of traditional immobilization using the backboard? None. To date, there is no compelling evidence that pre-hospital spinal immobilization improves patient outcomes. Now, that being said, absence of proof is not the same thing as proof of absence. In other words, it's at least possible that the board does do some good. It's just that no one's been able to prove it yet. So I thought at the time, big deal. So we immobilize a bunch of people who don't really need it before we get to someone who does. What's the harm in continuing to backboard people just in case? I was that 1 in a million. I didn't want to be just a number, because it wasn't a number for me. It would have been paralysis, right? But, you know, I looked at it and said, no proven benefit is not the same thing as saying that it's a contraindication. So I asked a doctor about this, and his reply was that we needed to get rid of the backboard because you would have to immobilize something like 392 patients before you would get to one who might actually benefit from it. Again, I was not very moved by that 1 in a million number, or in this case, 1 in 392. And he also said that the backboard does more harm than good. Well, that got my attention. I said, what kind of harm are we talking about here? You know what this doctor told me? His response was pain and pressure ulcers. I was less than inspired by that answer. So I set out at that point to do my own research, and later found out that the list of negative consequences for traditional immobilization, it goes well beyond just discomfort and pressure ulcers. So let's start with penetrating trauma, because that was one of the first things to be scratched off the list of indications for spinal immobilization. Oh, and speaking of penetrating trauma, this is Bubba. So Bubba and his brother Daryl, they're out deer hunting, and, you know, understandably, Bubba was mistaken for a white-tailed deer, obviously. So he was shot in the back of the head with an aluminum arrow. Ultimately, the arrow had to be cut down for him to be transported to the hospital, where the surgery to remove the arrow from his head involved removing a piece of the skull as well. Now, I'm sad to say that Bubba did experience permanent brain damage from this event, but thankfully, he was from Jefferson County, so no one could really tell the difference. Just kidding, if any of you are from Jefferson County. I can say that because my wife is from there. Okay, moving on. So the reason why we immobilized people with penetrating trauma, again, it wasn't because we had evidence to support it. It just seemed to make sense. If you get shot in the torso, we had no idea where that bullet traveled. It might have bounced off a rib and hit the spine. We just didn't know. So it seemed to make sense that we immobilized them. But then one day, researchers began to ask the question, does this really do anything at all? And one such study, conducted back in 2010, involved research finding that you have to backboard 1,032 patients with penetrating trauma before you'll ultimately get to one with an unstable fracture that might benefit from being immobilized. On the other hand, you would only have to backboard 66 of these patients before you would contribute to the death of one. How is that possible? How would we contribute to the death of a patient under these circumstances? Well, there was a study that looked at 357 patients with gunshot wounds to the torso. And while almost none of them would have benefited from being immobilized, there were several other life-saving interventions that those people did need. For example, 41% needed to be intubated in the field. 55% needed immediate emergency surgery. And what they came to the conclusion of was that immobilization meant more time spent on scene. And though it might have been maybe 10 to 15 minutes more on scene, that might have made the difference between life and death for someone who had perhaps a lacerated liver or a punctured spleen or something of that nature. Because there are more things inside your torso than just your spinal cord. So the delay in transport is thought to be the mechanism by which immobilization of these penetrating trauma patients ends up resulting in death or contributing to it. But that's penetrating trauma. What about other forms of trauma? What I discovered through my research was that the list of potentially harmful effects is almost literally a mile long. So if you think about it, the board itself being kept in the supine position, being strapped down, having a C-collar in place, can you imagine some potential problems that could create? Can anyone come up with a hypothesis here? Because I imagine that many of you could come up with some ideas. So let's start out with this. What about airway control? Having a person immobilized makes it more difficult to intubate a patient and it takes longer. Could that be problematic? Absolutely. And what about this? Aspiration. Having someone secured to a backboard inhibits their ability to protect their own airway. And what did we do whenever a patient immobilized to a board started to vomit? We did this. In decades of immobilizing patients, this was our solution: tilting the board on its side. Now, it doesn't matter how well you strap someone down, you cannot do this without causing some lateral movement of the spine, which is exactly what we're trying to prevent by using the board. And honestly, when's the last time you spent 15 minutes on scene padding the voids? I think I can rest my case there. And even if you did manage to strap someone down tight enough to prevent motion, how might those chest straps impact a person's ability to breathe? Chest expansion could be prevented. And they have also done studies on this and found that even in perfectly healthy young adults, being immobilized to the board reduces respiratory effectiveness by as much as 15 to 20%. And that is even more pronounced at extremes of age. Some other consequences here: intracranial pressure. We've known for quite some time that a C-collar that's improperly placed, maybe too tight or improperly sized, could increase intracranial pressure, which Could be especially harmful if your patient happens to have a traumatic brain injury, which, by the way, have you ever been taught that a patient with a spine injury ought to be assumed to have head trauma as well? Sometimes the two do go together. So a lot of times the thinking here is that the intracranial pressure would increase if you are impeding blood return from the head to the heart via the jugular veins, by closing them off, impeding the blood flow. And then lastly, another negative consequence, neurological injury. That's right, the very thing we're trying to prevent by immobilizing the patient. How is that possible? How can immobilization actually contribute to secondary neurological injury? This one absolutely blew my mind. So this was a 1998 study that looked at neurological outcome after immobilization versus non-immobilization. They looked at a group of 334 patients in the United States, all of whom had been immobilized, and compared that against a group of 120 patients in Malaysia, none of whom were immobilized. Turns out that the group that was immobilized was twice as likely to suffer secondary neurologic injury. The author suggests that spinal immobilization may increase the risk of neurological injury secondary to tissue hypoxia that may have resulted from a delay in transport to definitive care. Or at the very least, they concluded that the benefit of immobilization is very, very small. So what they concluded was that while there was not any evidence to support a significant benefit, there was a good possibility that immobilization was indirectly leading to worse outcomes. And all of that builds up to this final consequence, which is a pretty significant one, I think, and that is death. But there's another one that I think is a pretty big problem with immobilization. It doesn't even immobilize. Call me crazy, but that sounds like a pretty big problem. The one thing it was supposed to do, and it doesn't truly do it. It reminds me of having good intentions, but disappointing results. Kind of like if you change the oil on your car, but before you pour the new oil in, you forgot to replace the drain plug. Great intention, but the results were less than favorable. So we have to change with the times and the information we have. So what can we do to limit motion of the spine without creating all of these other horrendous problems? Well, I'm glad you asked that question. First, it may sound like splitting hairs and just quibbling over terminology, but we have to let go of traditional immobilization and replace it with what we call spinal motion restriction, or SMR is how I'll refer to it from here on. Now, it may sound again like we're just changing terminology for no reason, and it means the same thing, but that's not true. SMR is significantly different in that it supplies options. You can use devices other than the backboard to accomplish spinal motion restriction. You could even use something like a vacuum mattress or just the ambulance cot by itself. And in fact, even without a backboard, there was a 2018 study that showed that spinal motion restriction results in less motion than traditional spine immobilization using the backboard. So back in 2018, the NAEMSP and some other organizations here all came together and published a position statement in support of SMR. And you can see right there, this is what we do here now, using the ambulance cot primarily as our means of providing SMR. Now, one of the benefits to this is that SMR causes less pain. Now, why is that important? Not just for someone's temporary comfort, but long-term, what effect could this achieve? Think about pain in a person who is immobilized to a board. What effect might pain have on the patient's movement? A lot of times, those pressure points, they will try to reposition themselves to alleviate the pressure, to get comfortable. The motion is exactly what we're trying to prevent. And also, how might pain from the backboard impact the emergency department's physician, their physical exam? If the patient comes to the ER and the doctor says, hey, are you experiencing any neck or back pain? Even if they had no such pain prior to being immobilized at the scene, by the time they reach the doctor, their answer is going to be, yeah, my neck and back are killing me right now. And in those cases, physicians weren't able to rule out the possibility that spine injury was the source of the pain. So off to radiology they went to get exposed to unnecessary radiation. Granted, the amount of radiation they were exposed to may not have been that big of a deal, but it still was unnecessary, and that stuff does accumulate over time the more and more a person's exposed. So for transport, you can pretty much just skip the backboard and use the stretcher by itself. But what about getting the patient to the stretcher in the first place? Well, frankly, if they can walk, let them walk to the stretcher. In fact, there are studies that have shown that for conscious patients not under the influence of alcohol or drugs who have no distracting injuries and are not entrapped, letting them self-extricate is actually going to cause a lot less movement of the spine than using, say, the KED and traditional extrication methods. Now, as soon as I said KED, maybe some of you out there started having palpitations, but let me clarify. If I were to ask you if you have ever been in the middle of putting a KED on someone when you said to yourself, self, there is no way that this is not manipulating this person's spine right now. Does that sound familiar? Well, it turns out you were right. We now have evidence to support the fact that self-extrication causes a lot less movement of the spine than using the KED. One person said the KED takes a long time to apply and gives a false sense of motion restriction. Now, having said that, there will be times for the purpose of getting someone out of an entanglement situation inside a crumpled car where the KED may be your best option for getting them out, but not for the same reasons that we once thought. Oh, and by the way, have you ever arrived on the scene of a motor vehicle collision only to find the driver already out of his car and walking around on the scene and screaming into his cell phone? In those instances, do you recall the days when we used to perform standing takedowns? This was genius, right? We would go to a person standing up and take the backboard, position it behind them, and then a group of us would try to lower them along with the backboard onto the ground. And I guess we assumed that this was the safest thing to do. Unfortunately, that has not proven to be the case. Here's the thing. If they manage to get themselves out of the car and they're walking around before you get there, they can probably handle sitting their butt down on the stretcher. Just food for thought. If you only have a hammer in your toolbox, what happens? Everything begins to look like a nail. So in contrast to traditional immobilization, SMR gives you options, the freedom to be a critical thinking clinician. So exercise that freedom. Think outside the box. Nothing we do in this field is appropriate as a one-size-fits-all measure. Now, what about those patients who are unconscious or otherwise unable to self-extricate? So I already mentioned there'll be times when the KED is your best tool for getting someone out of an entanglement situation. But now, if you are having trouble giving up the backboard, I have good news. You could still use it for moving a patient from point A to point B, with point B being the stretcher. But you don't necessarily want to keep them on the board once you have them on the stretcher. So the board, though, is not the only option you have. What about this? The scoop stretcher. Part of the reason why I like the scoop over the backboard is that it eliminates the need to log roll the patient. Now, is that a big deal? Yeah, there's been evidence to show that the log roll maneuver itself causes greater displacement of the spine than a simple lift technique using the scoop. So you could say farewell to the log roll because it causes the very thing you were trying to prevent. Something else that's been emphasized a lot in the literature is the use of spinal clearance protocols. Now, prior to us essentially removing the board from our spinal trauma protocol, we started to implement clearance protocols. That was really the first change in a number of years that we made. And clearance protocols are nothing new. They've been around in one form or another since the late 80s, early 90s, and were originally used by ER physicians to rule out cervical spine injuries without having to expose their patients to unnecessary radiation from X-rays and CTs and such. But what I find so bizarre about all of this is that it took so long for EMS to start using these protocols. It's not like we were left in the dark. It wasn't a big hush-hush secret. It wasn't even something that EMS was prohibited from doing. In fact, the AAOS told us back in 1990 that patients with a positive mechanism of injury without signs and symptoms and with normal pain response may be treated without full spine immobilization. This was 1990. But better late than never. And today, EMS agencies around the globe are utilizing clearance algorithms, and there's a lot of research showing that they're doing so with great success. There are a number of clearance protocols to choose from, but we don't have time to talk about all of them, so I'm just going to key in on one of the more common, one of the oldest ones that's been examined quite a bit, and that's the Nexus criteria. The Nexus criteria is designed for use with victims of blunt trauma, and it looks for 5 things. Does the patient have a neurologic deficit like paralysis, paresthesias? Are they complaining of numbness or tingling? Do they have pain or tenderness along their spine? Are they presenting with an acutely altered level of consciousness? Are they intoxicated? Do they have a distracting injury? And if you answer no to all of these questions, it got you that much closer to ruling out the need to put them on a backboard. Nexus has been validated many, many times. In fact, in one of the earliest studies, they took a group of over 34,000 patients who had experienced blunt trauma and who ultimately were sent off to radiography to rule out spinal injuries. And what they did was they looked at this group of 34,000 patients, and before they sent them to the radiology department, they tried out the Nexus criteria. The goal was to see how many patients with spinal trauma would Nexus miss that ultimately radiology would catch. Ultimately, there were a total of 818 C-spine fractures found. Of that 818, Nexus identified 810, missing 8. But of those 8, only 1 needed surgery. But get this, that one patient, their fracture was not unstable. It's doubtful that pre-hospital immobilization would have been of any benefit to this person because they were paralyzed at the time of impact. It was a primary injury. The surgery that they received was simply for stabilization purposes as the patient began to learn to move around in a wheelchair. The bottom line is that Nexus and other criteria like it, they work very well and they're easy to use. So we've talked about a number of changes in the way we manage spinal trauma, but are there any other changes on the horizon? The answer is a resounding maybe. Take a look at this. There is a debate, an ongoing debate as to whether or not C-collars do more harm than good. We've known for quite some time, as I said earlier, that improperly used, a collar can increase intracranial pressure, and that makes it potentially devastating for patients with traumatic brain injuries. But the collars also hide areas of the head and neck, increasing the chance that we might miss signs of a life-threatening injury or an evolving problem like swelling and expanding hematoma, tracheal deviation, things of that sort. And because they cause pain, C-collars may lead to undesirable movement in patients who are only moving because they're trying to relieve pressure. But here's another potential problem that I find really fascinating. And there's been a few studies like this, but they're all pretty small. So I throw that caveat out here. But they looked at a group of cadavers. So recently deceased persons, and what they did was they took scalpels and simulated a severe spinal injury, an unstable spinal injury. And then they took C-collars and applied them according to the manufacturer's instructions. And what they found was that in every single case, there was pathological separation between the vertebrae, as much as 11 millimeters. That may not sound like a lot, but it really is. Now, don't misunderstand me here. I am not suggesting that we toss the no-neck collars out the window just yet. C-collars are still considered the standard of care. My point is, don't be surprised if that changes as more and more research comes out. For now, though, the big takeaway point here is, just like backboards, C-collars are not benign. Used improperly, they could do serious harm. Maybe it's time we get back to the basics and reevaluate how our use of C-collars is really holding up. Are we doing it right? Now, one study, the reason I mentioned this, and I'm only halfway joking, one study looked at this and found that when experienced emergency personnel placed C-collars, regardless of each provider's level of experience or confidence, only 11% placed the collars correctly. So the moral of the story is not every patient is a no-neck. You know, maybe if something changes with the whole C-collar thing, maybe what will end up happening is we'll just end up having to tell the patient to hold their own neck in line. I don't know, could happen. We're coming up on a break here pretty quick, but before we do that, I just want to encourage you that, you know, our field is ever evolving. The science is always coming out with new data, and it can be frustrating at times to have to change the way we played the game for years. But at the same time, we have to accept those changes because we're only getting better at what we do. However, don't feel bad if you're skeptical when some radical change is proposed. It's okay to have doubts. It's okay to have questions, but please do not stop there. Answer those questions. It doesn't make you a cynic. It makes you a good clinician. Trust, but verify. We're going to talk a little bit about causes of spinal cord injury, and then we're going to delve more into the pathophysiology of different types of cord injury. this is not going to come as a big shock to you, but motor vehicle collisions are still the #1 cause of spinal injury, followed by, and not too awfully far by, falls, particularly in the elderly. The falls from even standing height can be a risk factor for the elderly, especially if they're dealing with more brittle bones, osteoporosis, and things of that nature. When we talk about the pathophysiology of these different types of spinal cord injuries, we really have two kinds of spinal cord injury, one of which we can do almost nothing about, and that's the primary injury, which is the immediate result of the direct trauma. It's what happens as soon as the car collides with another vehicle or whatever the mechanism is. And there's nothing we can do for that. However, with secondary injuries, those are the things that can worsen a patient's outcome. So our goal in pre-hospital care is to recognize and prevent, or at least intervene whenever a secondary problem appears, because those are the things where we can have an impact on the patient's outcome. Secondary injuries, causes, the intrinsic ones, these are those that directly involve the central nervous system tissue. So it's things internal to the spinal cord and the spinal canal. So edema, swelling of the spinal cord, putting pressure on the nerve fibers, resulting in nerve damage, neurologic deficit, hematomas, things that would cause bleeding into the spinal canal or within the spinal tissue, resulting in nerve damage, and then intracranial pressure. The spinal canal, just like the area surrounding the brain, it's filled with cerebrospinal fluid, and even a small amount of swelling into the area or bleeding into the area can increase pressure to the point where it can become dangerous. So not only is the brain affected, but the cord can be affected as well. And then seizures. Any tonic-clonic movement can worsen spinal cord injuries, maybe because of the movement of the displaced vertebrae during the seizure, but also because of the increased electrical activity, metabolic activity that goes along with seizures can also worsen a spinal cord injury. So we definitely want to get a handle on all of those as quickly as we can. Systemic causes of secondary injuries include things that they affect the central nervous system tissue, but they're not directly in the central nervous system. So things like hemorrhage with anemia, anything that causes a lack of blood flow to the ischemic injury site is going to worsen, going to make that the extent of the injury broaden out. Anything that causes hypotension goes right along with that, resulting in shock and decreasing oxygen delivery to the tissue of the spinal cord. And that will eventually cause tissues in the immediate area to switch over to anaerobic metabolism, which can produce lactic acid, which left in that area of sufficient amounts can be toxic to the tissues, causing further damage, aggravating the injury. And then any, whether the carbon dioxide levels in the blood are too high or too low, same thing goes for oxygen. Those can impact vasodilation and constriction, impacting the oxygen delivery to the tissues, as well as having an impact on blood flow and blood pressure. And then, of course, abnormalities with blood glucose will also have an impact, as it can impede the production of ATP and essentially begin to starve the cells affected by hypoglycemia, which is far more dangerous and potentially devastating in our environment. So let's talk about the decision-making process for spinal motion restriction. First off, when we suspect spinal cord injury, it may begin with a suspicion based on the mechanism of injury. But as we have kind of led up to this point saying, the mechanism of injury alone is not the best reason to put someone in spinal motion restriction if that's all you have to go on. The way motor vehicles are produced these days, they can look a lot worse than what they are for the person inside. Modern vehicles, as one firefighter once put it, that the cake box can be crumpled, but the cake inside is just fine. So that's definitely made a change as far as the kind of impact that MOI should play on our suspicions. So we'll start with our suspicions based on the MOI, but then our continued decision to provide spinal precautions will be based on the totality of our assessment. So it's a multifaceted approach. In general, indications for spinal motion restriction will include things like blunt mechanisms that produced a violent impact on the head, neck, torso, or pelvis, incidents that produce sudden acceleration or deceleration, lateral bending of the neck and torso, any fall from a height, especially in the elderly, an ejection or fall, and of course, any shallow water diving incident that would cause a compression of the spine. So ultimately, the decision to use SMR is going to consider multiple factors, and having the clinical judgment necessary to make these informed decisions is only possible when we have a deeper understanding of the underlying pathophysiology. The thing of it is, we can't treat every patient with a cookie cutter solution. The question to ask is not what is the MOI so much as what do I need to do for this particular patient in order to prevent secondary injury. And we'll talk about spinal shock and neurogenic shock here in just a few minutes, but for now, know that our goal in the treatment of neurogenic shock is to maintain good perfusion to the spinal cord and prevent further damage. In most cases, this is going to mean having a target systolic blood pressure in these patients of around 90. You don't want to go too much more than that, but you definitely don't want to fall below that as well. We'll talk about that more in just a moment. And just as a quick reminder, this is Scav Protocol 304-8. If it's been a while since you've looked at it, just a quick reminder of what's included on here. It is almost verbatim things that we've talked about up to this point. You'll see a lot of things in these lists that very closely resembles the criteria found in the Nexus protocol. And then, of course, moving on down, depending on what we find, and answering the question of whether or not they're able to self-extricate, and then making the decision how we want to get them from point A to point B. So now let's talk about cord lesions, the cord injuries themselves. And when we talk about lesions in the context of a spinal cord injury, what we mean is essentially a tear of the spinal cord. So complete cord lesions then is obviously when the patient's spinal cord has been damaged all the way through. And the result is going to be paralysis and complete loss of sensation and motor function and so forth from the level of the injury down. You're going to see things like blood vessel dilation from the side of the injury downward, such as what occurs with neurogenic shock. But you also have incomplete cord lesions where only a portion of the cord is damaged partway through. And there are 3 syndromes in particular that we're going to touch on here real quickly. We've already kind of talked about anterior cord syndrome. That's the one that I was at most risk of with the teardrop fracture. It's the result of bony fragments or pressure going into the spinal canal and putting pressure on the spinal arteries. And there are 2 others we'll touch on here as well. To really understand the pathophysiology here, and I don't expect everybody to have this memorized after today, but just to give you a visual representation, understanding these different nerve tracts as they travel up and down the spinal cord and where they exit the spinal cord and go out to various parts of the body really kind of helps to put this into a perspective that you can visualize. So for starters here, you've got a nerve tract that is responsible for the sensation of pain and temperature. You'll see that that tract is right there in this instance. And you also notice that the fiber going out to the body crosses over to the opposite side of the cord. So this is the patient's right side, so the right side of the spinal cord, but this fiber is traveling across, or the term is decussate, it is decussating, crossing over to the opposite side of the body. So the right side of the cord is responsible for pain and temperature sensation on the left side of the body, and vice versa. Then you have on the posterior side, the nerve tract responsible for providing sensation and information to the brain about body position and vibration. And that is going to occur on the same side of the body as the side of the cord. So this is the left side of the patient's cord. It is connected to the left side of the patient's body. And then finally, the motor tract here. We've got the fiber coming off the motor tract going to different parts of the body on the same side. So again, patient's right side of their cord is innervating the right side of their body. So with just that as kind of the background music to what we're talking about here next, maybe this will help make more sense out of what we see in patients with these different types of syndromes. So with an anterior cord injury, we're saying that the front surface of the cord has been damaged here, which means that we've had damage to the pain and temperature tract here. And it would actually be on both sides. But not only that, you also have motor function. Even though the major tract is back here undamaged, the fiber that goes out to the body comes up into the anterior section of the cord before it exits to go out to the body parts. So you would end up having a severing of that fiber as well. Ultimately, what you end up with is a loss of motor function, and also loss of pain and temperature sensation from the injury site down. And then we have central cord syndrome. Now, this one is usually the result of hyperextension of the cervical vertebrae. You could think of like a person who is in their car with their headrest too low. They're sitting at a stoplight when someone rams into the back of their car, causing their head to fly backwards and basically turning that headrest into a fulcrum, causing hyperextension and causing damage to the central portion of the cord. And again, looking at our image here, if you imagine the damage being here, you can see how many fibers and nerve tracts are going to be damaged. And depending on how wide this area is, it's going to affect the extent of their sensory loss because it tends to be very variable. Same thing goes with the paralysis, but the upper limbs tend to be more affected than the lower limbs. And that is because the limb fibers, the upper limb fibers, are closer to the center of the cord than the lower extremities. And then lastly, this one's extremely rare. It's called brown-sequard syndrome, and when I say it's rare, it makes sense because it's caused almost exclusively by penetrating trauma, which, as we said earlier in the presentation, is itself rare, but ultimately results in hemitranssection of the spinal cord and affects that one side of the cord, resulting in weakness and loss of positioning sensation on the same side as the side of the cord injury, and then loss of pain and temperature sensation rather, on the opposite side. So again, just a quick visual of how that would impact these different fibers and tracts. Now, what's a little bit of interesting trivia here for you. Brown-sequard syndrome is named for the first person who described it back in the early to mid 1850s. His name is Charles Edouard Brown-sequard, and his observations were based on machete injuries in sugarcane farmers. But then in the late 1800s, a man by the name of Paul Loy confirmed Sequard's findings through a pretty interesting approach. So his laboratory in Paris, they study this phenomenon by decapitating hundreds of dogs. All right, enough of that. Just interesting trivia. No offense to the dog lovers out there. I'm right there with you. Wouldn't be able to conduct that study these days. Anyway, so real quickly, I just want to touch on spinal shock versus neurogenic shock. The reality is that in the pre-hospital environment, we're probably not going to be able to distinguish between the two, and our management really is not going to differ either. But just for the sake of information, I want to give you just a little bit of information on what the defining characteristics, how we contrast between these two. Spinal shock in general is an immediate temporary loss of power, sensation, and reflexes below the level of the injury. I say immediate. Sometimes it can take days or even a couple of weeks before it sets in. It just depends. But then neurogenic shock is a sudden loss of sympathetic nervous system tone. So the sympathetic nervous system, the signals going out to the vasculature, the blood vessels in the body, that signal is interrupted such that the blood vessels no longer get those signals below the level of the injury. So all of those blood vessels go wide open. They dilate, and it results in sudden hypotension and decreased preload to the heart. And that's also why you see the warm red skin below the level of the injury. And just as a quick way to visualize in your mind's eye neurogenic shock and why it produces shock is when the cord is injured and the sympathetic nervous system has been cut off from the rest of the body below the level of the injury. It causes shock, not because there's a loss of blood volume, it's the same, but the size of the container of that blood is much larger when the vessels dilate, resulting in the lowered blood pressure. Now, I want to transition from these two forms of shock to a discussion real briefly on autonomic dysreflexia. It's also referred to as autonomic hyer-reflexia. And this particular phenomenon isn't something that you're likely to see at the scene of an accident, but rather you may find it in a patient who had a spinal cord injury years earlier, and maybe you respond to their home when they are experiencing life-threatening hypertension and some other symptoms that we'll discuss here in just a moment. and it is truly a life-threatening situation. So I want you to be able to recognize it when you see it and know of some of the things that we can do pre-hospital to hopefully make an impact on it. But we'll let this video kind of transition us into that focus. Okay, so let's key in here more on autonomic dysreflexia. So to really explain this succinctly, I'm going to turn it over to a physician and show you some videos to better explain it.
Okay, we're going to talk about autonomic dysreflexia, also called autonomic hyer-reflexia. This is a medical emergency that afflicts spinal cord injury patients when the injury falls above the level of T7.
In the event of a spinal cord injury, the autonomic nervous system continues to function but is unable to communicate with your brain due to an interruption at the level of the injury. The body sends a message of pain or discomfort to your spinal cord. Your spinal cord tries to send these messages to your brain, but because of your injury, the message is blocked, which is probably why you cannot feel the pain in the first place.
So what happens is the autonomic nervous system is sensing this and sends the sympathetic nervous system signals, and the vessels vasoconstrict below the level of the lesion.
This process squeezes extra blood into the blood vessels and the rest of your body. The extra blood, in conjunction with the tightly squeezed blood vessels, makes your blood pressure go up quickly.
So as the vessels are continuing to constrict to try to send signals to the brain, what happens is before it even gets to the brain, these baroreceptors now in the carotids and the aortic arch know that it's supposed to relax the vessels, but it can't get the signal down to lower the blood pressure in the lower extremities because the cord is severed. So what you get is vasodilation above the level of the injury and vasoconstriction causing very dangerous hypertensive blood pressures below the level of the injury, and the vagus nerve causes a bradycardia. So you get severe hypertension and bradycardia.
Autonomic dysreflexia can be very dangerous. It can cause a rapid increase in your blood pressure. High blood pressure is a serious medical situation. It could lead to stroke, seizure, and even death.
So let's look at other assessments. The patient is going to start to complain of a severe pounding headache from all that blood going into the head. Facial flushing along with this headache because the vessels are vasodilated, remember, above the level of the injury. Diaphoresis, sympathetic nervous system response. first thing to do is raise the head of the bed. This way at least that pressure comes down from the head. The next thing you do is find the pain stimulus. That's the only thing that's going to reverse this. The most common problem or cause of autonomic dysreflexia, I've read like 9 out of 10 cases, it's due to a distended bladder. So either the patient can't empty it or their Foley is kinked. So those are 2 really important assessments to make upon quick view of your patient. Or the other big cause is an impacted bowel or a full bowel. There could be any number of reasons though when you've already ruled out these 2 big reasons. So the patient could have a pressure ulcer, their belt could be too tight, their shoelace could be too tight, their sheet could be wrinkled underneath them. I remember I used to have a student come in who got their first job on a spinal cord injury unit, and she said that her and her colleagues would walk around and remove those little Foley clips from the bed because that was a big cause of autonomic dysreflexia on her unit. So she hated those little Foley clips.
Think of it this way. If there is any stimulation below your level of injury that would have been painful or unpleasant before your injury, it could now cause an episode of AD.
Okay, so there you have a succinct explanation of autonomic dysreflexia. So to underscore some of the points of most interest to us, again, this is something that is most likely to be seen in someone with a pre-existing spinal cord injury. They have a lifelong risk of something like this happening. Primarily, it's in persons with an injury that occurred at or below T6. But as you heard them state in the video, the number 1 trigger tends to be a full bladder. Now, maybe they have a catheter in place and the tubing has become kinked. Maybe the collection bag has reached a point where it's so full that no other relief is possible. And because they don't sense the discomfort consciously, they may not be aware that that's what's going on and causing these symptoms that they're experiencing. Some other potential causes would be like restrictive clothing and anything that is causing pressure or would otherwise cause pain. Maybe they are sitting on something that's poking into their side and they just are completely unaware of that object. So for us, that means that we could investigate for potential causes here if there's anything in the pre-hospital arena that we can have an impact on. Maybe it's as simple as checking the Foley catheter or what have you and seeing if the tubing is kinked or if the collection bag needs to be emptied. That's something that we could do fairly easily. If they're sitting on something or laying on something that we could remove, maybe that would start to reverse the effects. Still, this is not someone that you're going to treat and release at the scene. You're still going to transport them, and there are going to be times where the stimulus is not something that we can take care of in the field. But just know that there are some of these more common ones that we could make a relatively fast, immediate intervention that could begin to reverse the effects. So just be on the lookout for that.